our participants range with a number of different backgrounds, from MBA to insurance to workers' compensation to employers and healthcare practitioners and disability case managers, human resources, health and safety. So we're really excited to share information with you and impart some of our knowledge that we have on current subject matter, which is timely, evidence-based, and applicable to your everyday work. A huge thank you to our expert panel of speakers today, our conference team and our conference sponsor, Ortho Canada. They've all helped us accomplish putting together this conference to share this information with you. And as we move through the life cycle of care from injury to resilience, I hope you find suggestions and ideas offered that will be of benefit to you in your work. The Lifemark Health Group would like to acknowledge that our work spans many territories and treaty areas, and we are grateful for the traditional knowledge keepers and elders who are with us today, those who have gone before us, and the youth that inspire us. We recognize the land and the benefits it provides to all of us, and we invite everyone to reflect on the past and present history in their particular geographic area, and for us each to think about what we can do to work towards reconciliation. As you've noticed, we are recording today's conference, and we will be sending a link following in case you wish to re-listen to a speaker or want to share it with colleagues in your organizations. Before we start, there's been a lot of work put together, as mentioned, and we are really hoping to add to your knowledge base and give you some additional tools for your toolbox. The form of our session today is for each speaker to have approximately 25 minutes to present, followed by 5 to 10 minutes for a question and answer session. If you have questions for our speakers, feel free to pop them into the Teams Q&A, and the moderator will raise them during that QA time. JC from our team is our moderator today, and she'll verbalize your questions to our speakers. To add a question and wondering where is that Q&A box, just click on the Q&A, the button in the menu bar at the top of the screen, and type in your question. Unfortunately, with a group of this size, you won't be able to turn your cameras on or ask questions verbally, so please use the Q&A for your questions. Please note, chat has been disabled as it can be a little bit distracting when the speakers are talking, and it's really hard then for us to scroll through and find the Q&A. So that's why we're using the Q&A box today. After the second presentation, we're going to have a short 5-minute break so you can refresh your coffee, stretch your legs, take a micro break. And when we return, we'll have our final presentation and closing remarks for today. We will, as mentioned, send out a video link to you. You can access it for the next 3 months. And along with that, you're going to receive a post-event survey. So we'd like to know more about what topics you'd like to hear about as we start to plan our fall conference, which will be held in October or November. At this point, I'd like to introduce Karine Kempf, our clinic director at Universal, to introduce our first speakers for today.
Thank you so much, Julia. Good morning, good afternoon, everyone. What a pleasure to be here. I have the pleasure of introducing our first speakers that will join together to present the sources of perceived injustice following occupational injury. Dr. Michael Sullivan is currently professor of psychology, medicine, and neurology at McGill University in Montreal, Quebec. He also holds cross appointments with the School of Physical and Occupational Therapy and is scientific director of the Center of Research on Pain, Disability, and Social Integration. He has lectured nationally and internationally on the social and behavioral determinants of pain-related disability. Dr. Sullivan has published over 200 scientific papers, 25 chapters, and 5 books. He currently holds a Canada Research Chair in Behavioral Health. In 2011, Dr. Sullivan received the Canadian Psychological Association Award for distinguished contributions to psychology as a profession. As well, We will be joined by Antonina Pavilanes, a PhD candidate in clinical psychology at McGill University in Montreal, Quebec as well. Antonina is pursuing her PhD in clinical psychology under the supervision of Dr. Sullivan. Over the last few years, she has held research positions at Mount Allison University, the University of Southern Denmark, McGill University, and the Research Institute of the McGill University Health Center. Her dedication to advancing healthcare research extends to her involvement at the Besserer Center for Global Family Medicine and the Quebec Network for Junior Pain Investigators. Antonina's current research focus is twofold. Firstly, she is examining the role of post-injury perceptions of injustice as a determinant of PTSD symptom severity. Simultaneously, she is exploring the psychological and physical factors that determine the onset of PTSD symptoms in individuals who have contracted COVID-19. This upcoming presentation will briefly describe the results of a program of research that examined the causes and consequences of perceived injustice in the weeks immediately following occupational injury. Dr. Sullivan will summarize the results of interviews with injured workers about factors and that contributed to their perceptions of injustice. Ms. Pavilanes will summarize findings relevant to the relation between perceived injustice and post-traumatic stress symptoms. Without further wait, here's Dr. Sullivan and Ms. Pavilanes. Enjoy.
Right. Hopefully that has all happened as it should. Anyway, thank you very much for this very kind introduction and also this very gracious invitation. So Antonina and I, in the time that we have today, are going to share with you some of the results of a program of research that we've been conducting examining the causes and consequences of perceptions of injustice following occupational injury. Now, human beings appear to have a propensity to evaluate or appraise their life experiences in terms of justice principles. And some of these justice principles might include distributive justice, the idea that everybody gets the same or their fair share, retributive justice, the idea that people should be punished for their transgressions, compensatory justice, that victims should be compensated for the actions of a transgressor, and interpersonal justice, that people should be treated with respect and dignity. Now, this propensity to experience or to evaluate our experiences in terms of justice principles appears to emerge quite early in life. And for those of you who have children, you'll no doubt be able to recount a number of occasions where one of your children reacted with intensity at the perception of an unjust situation, often involving the, let's say, preferential treatment of a sibling. And this propensity to evaluate or appraise life experiences in terms of justice principles does not appear to be restricted to human beings. Some of Frans de Waal's work shows that different primates show the same propensity. So we became interested in perceptions of injustice and some of the work that we were doing with individuals who had sustained injuries in motor vehicle accidents, so individuals with whiplash injuries. And we were struck by the degree or the frequency with which themes of injustice seem to be woven through the fabric of their narrative. So statements like, why me? What did I do to deserve this? And why is God punishing me like this? And it was our clinical impression that individuals who spoke in a manner that that basically reflected themes of injustice seemed to progress more slowly in their rehabilitation interventions. So we decided to launch a program of research examining the impact of perceptions of injustice on recovery following injury. So at that time, there was no measure that had been developed to assess perceptions of injustice. So that was one of the first steps in this program of research. And we developed the Injustice Experiences Questionnaire, which is a 12-item questionnaire where individuals are asked to indicate the frequency with which they experience different injustice appraisals in relation to their injury. So some of the items on the IQ include, it all seems so unfair. Can't believe that this has happened to me. I just want to have my life back. Nothing will ever make up for all that I've gone through. So one of the things that's been very consistent in this area is the role that perceived injustice seems to play in predicting poor recovery outcomes. So approximately 500 studies have been conducted so far on the causes and consequences of perceived injustice. And high levels of perceived injustice appear to contribute to more severe pain, more severe depression, and also more prolonged occupational disability. Another thing that's emerged from this literature is that compared to other psychosocial risk factors is that perceived injustice seems to be more resistant to change. So that when we look at how perceptions of injustice change through some of our traditional approaches to the management of individuals with persistent pain conditions, such as pain management programs or interdisciplinary pain programs, is that we see that perceptions of injustice essentially don't respond to those types of interventions. Recently, 2 systematic reviews have been conducted showing that high levels of perceived injustice are strong predictors of pain-related disability and strong predictors of depression in individuals with musculoskeletal conditions. And so the consistency and the robustness of this finding really calls for the development of interventions that are specifically designed to target or to reduce perceptions of injustice. And so this was essentially the question that prompted the study. We're interested in knowing what are the factors immediately following injury that seem to contribute to an individual's perceptions of injustice. If you're going to develop an intervention to target perceptions of injustice, you need to know something about the factors that are contributing to an individual's sense of injustice. So in this study, we recruited individuals as soon after a work-related injury as possible. And most of these actually were recruited from Lifemark clinics in the Montreal region. And we asked individuals to complete the Injustice Experiences Questionnaire on a weekly basis for 6 weeks. And so these are scored automatically. And as soon as someone obtained a score of 18 or above, which is sort of like the threshold for high levels of perceived injustice, someone from our center contacted the individual and interviewed them about their sources of injustice. And so the interview results revealed 3 dominant themes, one of them being invalidation, undeserved suffering, and blame. So validation, essentially, it's characterized by the sense of being heard, of being understood, and being believed. So invalidation is basically a situation where the individual does not feel heard, does not feel understood, does not feel believed. And we saw invalidation come out as a major theme in many, many different contexts, so that there was interpersonal invalidation. I can tell you that it's my family, my spouse. He doesn't realize that I can't do everything at home. He wants me to do all the stuff I used to do, but I can't do it all because I have pain and I don't want to make it worse on purpose. He doesn't understand. Invalidation from the employer. Therefore, I feel it's quite unfair that I've had to fight for and be questioned about the level of my pain after this incident. I just feel completely unsupported by my employer and the whole healthcare system of Quebec. Invalidation by medical professionals. I had to push a lot to get tests added to prove my condition. There was no one who believed me. You know, I had to ask for an EMG several times. It seems that they didn't believe the part of my leg that is affected. I had to prove several times that my back pain is real. Validation from the insurer. I was harassed at work. I was told I was faking my injuries. The CNSST, which is the Workers' Compensation Board in Quebec, got involved. And when they investigated, they accused me of faking it. So undeserved suffering was another dominant theme in the individual's responses to the interview. And here it's basically responses that gave a sense that individuals felt that they were being punished for something that they hadn't done. So I don't think it's fair that this happened to me. I don't wish it on anyone else, but I think it's unfair that I'm the one who's stuck with it and I have it all the time. And here's just a slight digression here about how we tend to feel that we are being punished or that we are being unfairly punished when we experience pain. And so the word pain in several languages, including French, Dutch, German, and Spanish, can be traced to the Latin word puina, which refers to some form of penalty or suffering inflicted as a punishment for an offense. So the experience of pain may be inextricably woven to our semantic representations of justice. And blame was another area that was characterized by a lot of the interview responses. And the individuals that were identified as to blame or responsible for the client's difficult situation were the health professional, the insurer, and the employer. And that's the order of frequency as well. So even though the injury occurred in the workplace, is that the health professional was more likely than anyone else to be identified as the source of injustice by the client or the injured worker. So this is the paper that summarizes some of these findings if you were interested in examining it further. So avenues of intervention. Are we any closer to developing an intervention that is going to be effective in reducing individuals' perceptions of injustice following injury? Well, the first step is going to be screening. In order to intervene on a factor, you want to be able to identify the individuals for whom that factor is problematic. So identifying individuals experiencing elevated levels of perceived injustice. And here we have a number of different options. So we have the Injustice Experiences Questionnaire, the IEQ, that we've used in many studies with individuals who have sustained injuries, debilitating injuries. The IEQ-G is essentially the same measure, except that the instructional set has been modified so that it doesn't pertain specifically to injury. So it's an instrument that can be used for individuals who have a debilitating health or mental health condition, not necessarily restricted to injury, and the IEQ-SF, which is a shorter version of the IEQ. And individuals responding to these measures are asked to indicate the frequency with which they experience these different thoughts and feelings. And then we obtain the algebraic sum of the individual's responses, and they are interpreted in this manner. So for the IEQ or the IEQ-G, individuals who would be obtaining a score of 18 or more would be individuals who would be considered at risk for problematic outcome. On the IEQ short form, individuals that obtain a score between 4 and 6 would be considered to be individuals that are at high risk for problematic outcomes. So if we're going to be building an intervention to target perceptions of injustice, what is it going to have to include? Well, it's going to have to include validation, because that was the dominant theme that came through most of the responses. And we've been doing some research looking at the use of guided disclosure interviews, fostering expression, and also reattributions of others in validating communication. And at a later point, I might be able to provide you with a bit more information on exactly how one uses these different types of techniques. We've also been testing a technique that we refer to as injustice-focused problem solving, where what we do is that, as on the basis of the individual's responses to the IQ, we try to identify sources of injustice. And the sources of injustice, we invite the client to see these as problems that need to be solved or let go. And we work with the client towards either solving the problems or the factors that are contributing to a sense of injustice, or looking at ways in which we can accept them or let them go. In studies that have shown significant reductions in perceived injustice, it's becoming clear that reductions in perceived injustice leads to a reduction in the severity of symptoms. Oh, sorry, I went too fast there. That it leads to a reduction in disability and also contributes to more positive return to work outcomes. In an area as well where you have a situation where you're working with a variable that's difficult to change, you also need to be open to the idea of preventing perceptions of injustice from emerging in the first place. And I think that there's some possibilities in this area. Some of the things that people have identified as factors contributing to their sense of injustice include claim processing delays, disrespectful communication, and dismissive communication. Well, those are all things that are probably modifiable and and potentially preventable. So, to summarize, is that we need to be screening for perceptions of injustice. We need to be mindful of our communication and ensure that the way we're communicating with the client is going to be experienced by the client as validating. And we have to be looking at how we can incorporate techniques to prevent or manage perceptions of injustice in individuals that have sustained debilitating injuries. And that brings me to the end of my presentation. Thank you.
All right. So I'm going to be talking to you a bit more about the relationship between perceived injustice and post-traumatic stress symptoms. So when we hear the term PTSD, what immediately comes to mind? Maybe scenes of soldiers returning from war or survivors of big accidents. And it's true that traditionally post-traumatic stress disorder has been linked to these dramatic, high impact events. But if you go to the next slide, what if I told you that PTSD isn't confined to these narratives? What if I told you that PTSD-like symptoms can emerge in the most unexpected of places? So picture this, a cancer patient battling not just the disease itself, but also a psychological toll of their diagnosis. Or envision someone recovering from a severe burn injury, grappling not only with physical pain, but also with the haunting memories of the event. And let's not forget those living with chronic conditions like fibromyalgia, where every day can feel like an uphill battle against both physical and emotional distress. These are some of the faces of PTSD that we don't often see or talk about. Yet, if you click again, emerging research is shining a light on the prevalence of PTSD-like symptoms in these unexpected contexts, particularly among individuals dealing with chronic pain. Next slide. Now, you might be wondering, why should you care about identifying PTSD symptoms in your patients? Well, let me tell you. Understanding the presence of PTSD symptoms in your patients is crucial because it can profoundly impact their recovery potential. These symptoms have the power to impede progress in rehabilitation, exacerbate physical ailments, and diminish overall quality of life. So it's not just about addressing their physical aspects of the condition, but it's also about recognizing and addressing the psychological toll. Next slide. So before moving any further, I think it's important to acknowledge the stark reality that the number of disability claims stemming from mental health issues, notably PTSS, continues to soar. It's a concerning trend that demands our attention. If you click again, to shed light on this issue, I'm going to share some insights from a recent study that we conducted, looking into the specific role of perceived injustice in predicting PTSS severity among individuals with work-related musculoskeletal injuries. We examined the frequency of PTSS immediately following injury, and then explored the role of perceived injustice in perpetuating these symptoms. We worked with close to 200 individuals, all of whom were absent from work due to a work-related musculoskeletal injury. And these individuals completed a series of self-report measures online over 6 weeks at 3-week intervals, among which were the post-traumatic stress checklist to assess PTSS, and the Injustice Experiences Questionnaire to assess feelings of perceived injustice related to the event. I want to start by showing you the distribution of IEQ scores among our participants. What we found was that perceptions of injustice are really common in the immediate aftermath of injury. If you click again, here we can see that 65% of them fell into what we call the risk range, which means that a substantial amount of people perceived their situation as unjust. Now, why is this important? Because when patients feel like they've been treated unfairly or that their situation is unjust, that will exacerbate distress and likely hinder their ability to cope and heal. So how does this perception of injustice relate to PTSS? That's the question that drove our investigation further. And what we discovered was a pretty fascinating connection between the two. Next slide. Can we go to the next slide? Thanks. So early changes in perceived injustice predicted subsequent changes in PTSS. So in other words, the way that people perceived fairness or injustice in their situation following their accident had a direct impact on the development or alleviation of PTSS over time. But here's where it gets even more intriguing. It wasn't just a one-way street. We also found that PTSS predicted later changes in perceived injustice. Next slide. So this bidirectional relationship suggests a complex interplay between psychological perceptions and symptomatology, each influencing and shaping the other over time. So how do you know if your patients have PTSS? Next slide. The post-traumatic stress disorder checklist for DSM-5, which is commonly known as the PCL-5, is widely recognized and used for screening PTSS. What makes it so valuable is that it's very user-friendly. So it's designed to be straightforward and easy to administer, even in a busy clinical setting. By simply guiding your patients through a series of questions, you can actually gain pretty valuable insights into the presence and severity of their symptoms. What's most impactful about the PCL-5 is its ability to identify patients who may need further intervention. So you can think of it kind of as a compass that'll help you, or that'll help guide you towards those who may be silently struggling with the aftermath of a trauma. So now that you've identified PTSS in your patients, the question becomes, how can you help? So fortunately, several interventions have shown promise in reducing PTSS. One approach involves tackling the issue of perceived injustice head-on. By identifying sources of injustice and using problem resolution strategies, you can actually help alleviate the psychological burden that comes with these feelings of unfairness. Another potential treatment is acceptance and commitment therapy, known as ACT. ACT teaches patients to accept their thoughts and feelings without judgment while committing to actions aligned with their values. So this approach really empowers patients to live more fully in the present moment, even in the face of adversity. The last one I'll mention today is adaptive disclosure, which involves gradually and systematically confronting distressing memories or experiences in a supportive environment. So by providing a space for emotional processing and recovery, adaptive disclosure helps patients move forward from trauma and regain control over their lives. By incorporating these evidence-based approaches into your practice, you have the ability to provide comprehensive care and address both physical and psychological aspects of your patient's well-being. In wrapping up, next slide. It's clear that PTSS can, in fact, manifest in unexpected contexts, especially those intertwined with chronic pain and physical injury. Our study sheds light on a crucial aspect of managing PTSS, which is addressing perceived injustice. By recognizing and tackling sources of perceived unfairness or inequality, we can significantly alleviate the psychological burden that patients carry. It's also important to equip ourselves with the right tools for the job. So instruments like the PCL-5 are really invaluable in identifying and assessing PTSS. But beyond identification, it's the implementation of evidence-based interventions that truly allows us to support our patients on their path to recovery. So on that note, let's make sure that we're not just treating the physical ailments, but also addressing the psychological toll of events that are deemed traumatic. Because in doing so, we're not just providing care, but we're also offering hope and healing those who need it the most.
Perfect. Thank you very much. That was very informative. I will just remind the group that if you'd like to ask a question, please refer to the top line where it says Q&A, and you can add your question there. I would like to ask a question to either of the presenters. If we are working with someone that we think might have perceived injustice, is there something that we should avoid saying to those individuals, or is there something we can say to those individuals to help validate, as you had suggested initially?
Right, okay, so I'll field this one. So yes, there's as important as it is to say the right things, it's also equally important to try to avoid saying the wrong things. And especially one of the things that happens with pain is that because it is an invisible condition or an invisible disability, is that invalidation is just it's a very likely experience for individuals, in the sense that people with pain will feel that their pain is not being recognized or not being believed. In the same way that, it's like if you think of someone with a lower limb amputation, they very rarely talk about invalidation because it's clear to everyone that they've sustained a major loss. And that's not the case with pain conditions. So we have to be really mindful of the language that we're using. And some of the instances of invalidation that people experience are not necessarily, were not intended that way. So for the last 2 decades, we've been telling physicians to reassure the pain condition. We haven't exactly told them how best to do that. And some of the language that's sometimes used to reassure the patient can be experienced by the client as dismissive. And so I think it's making sure that we are not using a language that is going to be experienced by the client as dismissive or invalidating.
Thank you. Yes, that is fair, I think. And then what about with respect to anger? Because sometimes these feelings can progress into an angry state at times. And so is there, like, how does that change that interaction in that situation?
Right. So anger is one of the factors that contributes to perceptions of injustice impacting negatively on recovery potential. So that anger is the automatic emotional reaction to appraising a situation as unjust. So your clients who are high in perceived injustice are often very angry clients. And anger is going to present a challenge in many different levels. It's hard to build a strong working alliance with a client who's angry. That an angry client is going to have a tendency towards non-adherence or non-compliance, again, impacting negatively on your intervention outcomes. And so for the client who's angry, you need to address it with the client. It's one of these things where you just can't pretend that it's not there. You have to say, Jack, it's like every time you come in, I sense that, it's like you're angry. And I'm wondering, where is that coming from? And am I playing a role in that? So you want to make sure that there is nothing that you are doing as an interventionist that is inviting that anger from the clients, so that you're going to be able to build a working alliance that you need to move forward with the client. And so addressing it is going to be an important first step.
Perfect. Thank you so much.
So thank you, Dr. Sullivan and Antonina. We really appreciate you helping us better understand some of the current studies that and sources that are out there in relation to the perceived injustice in relation to people's injuries, and how these perceptions can contribute to post-traumatic stress, and some of the things that we can do around that in terms of acknowledging it and being careful about how we manage what we say. So thank you very much for sharing that with us today. I'd like to introduce Corinne back, who's going to introduce our next speaker.
Thank you, Julia. Is it just me, or I could listen to Dr. Sullivan for days and days? It's great. So interesting. Thank you so much. What a great presentation, guys. So I have now the pleasure to introduce Dr. Simon DeCarry. So Dr. DeCarry is an assistant professor of rehabilitation at the University of Sherbrooke in Quebec. He is also co-scientific director of Long COVID Web, a pan-Canadian network coordinating long COVID research. His research program advances the science of knowledge, mobilization, and implementation science to improve care for people living with chronic diseases and disabilities. This conference will delve into the science of shared decision-making for people living with chronic pain. Simon will highlight new results from the Decide Pain National Survey, in which over 1,500 people with chronic pain from the 10 Canadian provinces answered questions concerning if and how they were engaged in decisions about their care. We will discuss opportunities and future interventions to improve satisfaction and interaction with the healthcare systems. Without further wait, here is Dr. Simon DeCarry.
Thank you very much for the introduction. Is my PowerPoint working fine?
Perfectly.
Perfect. So let's go. Thank you very much for this warm introduction. And indeed, I also aim to become like Dr. Sullivan. So this was very, very interesting. Last time I presented to this audience, I was here to talk about long COVID. And I do still pretty much work with this population, but I do have also other research interests. And this is why I am coming to you today to talk about shared decision-making in chronic pain. So just keep in mind that shared decision-making is a complex topic. And right now, when we're giving workshop about this, it's approximately 3 hours long of different content. So today, it's really a teaser for you on the principle of shared decision-making to get you interested in these practices. And yeah, so just show you the way, because there is a lot of thing happening in shared decision making. So it's a teaser today, but I want to focus on the result of our pan-Canadian survey. And honestly, I'm super happy to present that because it's the first time we're presenting to a large audience, a large national audience. So 3 sections for my talk. First, we're going to talk about the definitions and the context. Then we're going to look at the result of the Canadian survey. And I'm going to end by some propositions for solutions. So let's introduce shared decision making. So in your clinical practice, have you ever said something like, well, this consultation was very complicated. We did not agree on the decisions, objective, and treatment options with the patient. So this is very common. More complex the cases are, more the situation is common. And this is exactly why shared decision making was designed, to navigate these complex situations. I just need to tell you the little story of how I discovered shared decision making. So when I was a PhD student in Montreal a few years ago, I was working at the Hôpital Maisonneuve-Rosemont in the east of the island of Montreal. And I was working in the diagnosis of MSK disorders. We were working with orthopedic surgeons. And during my PhD, we wanted to design a care model which linked primary care with the orthopedic clinic and basically offer a primary care clinic, a free public primary care clinic for patients, so that they did not overuse the system and they could receive services way before having to see the orthopedic surgeon. So a few years ago, this was pretty innovative. Happily, now it's more common practice across different provinces in Canada. So this is very good. But primary care is a unique environment to understand shared decision making. So when we talk about MSK condition, it's approximately 20% of all consultation in primary care that are for chronic pain and musculoskeletal disorders. And so the waiting list is enormous. And a particularity also is that when I began this clinical practice, I was new out of school, and we were exposed to sports medicine clinics and this type of clinical environment. But in the public system, people with MSK condition also have a lot of comorbidities and a lot of mental health comorbidities, which complexify the process of rehabilitation that we've seen in the books while we were students. So innovation was really needed in my physical therapy practice to deliver primary care. And in a primary care clinics, there is this very much important need to do a general practitioner and rehabilitation professional interprofessional collaboration. And this is how I discovered shared decision making. So the story is that in the first week of my clinical practice, so remember that I was fresh out of school, so I had built this beautiful clinic, and so at the time I did not have a lot of clinical experience. So I used my research skill because I was already going into research. So I said, well, let's do a primary care clinic based on the best available evidence. I'm going to use Cochrane reviews. I'm going to use systematic reviews. I'm going to design protocol of care based on exercise and education, and that will be my clinic. So in the first week, this gentleman, 80 years old male, came to the clinic with chronic neck pain. So I did my assessment. Nothing neurological in nature. And so I said to the person, well, we're going to do an exercise program because I have a systematic review that demonstrate the effectiveness. And the person told me, well, no, I want a massage. And by the way, I want a female giving me a massage. So already at that time, this kind of discussion, it was not good. And so I just said to the person, well, I'm sorry, I'm not going to deliver that intervention to you because I believe in my Cochrane review. And so the gentleman sadly made my first complaint in clinical practice. And when I met with my my physician boss at this time, he just said, well, what happened? I said, well, I have my protocol, evidence-based protocol, a systematic review. And he said, but why didn't you do shared decision-making with this person that would have solved your problem? So this is what happened in my first week of clinical practice. And fortunately, I used this traumatism to fuel my research interest, and I went into postdoc at Université Laval in primary care and in shared decision-making with Dr. France Légaré. And this is how this program was born out of a clinical situation that I had lived. So what is shared decision making exactly? Before I give you the definition, just give you some terms that you need to be aware when you go into this field. So shared decision making is part of a field of research which is called patient-oriented research. And so patient-oriented research is a national strategy. And you may know that in research, there are evidence gaps. And so there is an evidence gap between biomedical research and clinical trial for pharmacological approach. But in health services, there is also a gap between what you find in systematic review and implementation into practice. And patient-oriented research actually serves to close this gap. So you may know that there is 17 years. It takes 17 years to take an innovation. So patient-oriented research aims to reduce that knowledge gap as best as possible. And we do that by putting the patient first. So hearing patient lived experience and their values and their needs and preferences. This is how we do that. You're going to also learn about patient-centered care. So patient-centered care is an approach to health care in which the patient is at the center of the decisions that are taken for this person. You're also going to hear about patient partners. So patient partners are individuals who have received an episode of care, and then they join research team or clinical teams, and they inform about their lived experience to improve the quality of care. And so this all lead to shared decision making, which is actually operationalization of all these different terms into a clinical principle and a clinical technique. So shared decision making, it's a process by which a clinician and a person, or most likely name a patient, when they take a decision together on treatment options based on both the scientific evidence and the person values and preferences. So it's a paradigm shift about how information is exchanged between clinician and patient. It's a knowledge mobilization strategy, and keep in mind that it's profession specific. So a lot of shared decision making was developed for medical practices. And so we now know that integrating that in rehabilitation practices is very different for obvious reasons that I will show you in a moment. If we look at this from infographic view, so in the last decades, we had the paternalistic approach to healthcare. So the clinician had scientific evidence, the clinician had clinical experience, and so they interpreted the evidence and they were giving the patient, well, orders, protocols to follow for their health. And so now what we've learned over the decade is that, unfortunately, most of the scientific evidence in medicine is actually low, moderate quality. There is a gray zone. There is always people that don't fit with randomized control trial. And there is a statistic that goes that only 15% of all medical practices, diagnostic or treatments, are actually based on strong scientific evidence. And so that's why shared decision making is so important, because shared decision making actually make a feedback loop where the patient is exposed to the evidence and the gray zone, and they express their value and preferences that help make a decision based on this evidence that is not clear. And this is proposed for over a decade as the optimal way to provide patient care. So why should we do shared decision making? Why should we change the way we do practice? Well, shared decision making improves what we know so far. It improves relation and communication between the patient and the clinician. It helps patient to better understand probabilities of risk and benefits of treatment option. It encourages the patient to consider and express their expectation and their preference about their care. And it reduces the patient uncertainties about complex decision. And remind this word uncertainties, this is foreshadowing for what's coming next. And shared decision making is relevant in any part of healthcare decision, whether it's using prevention techniques, different types of diagnostic approaches, choosing the right pharmacological options, and even choosing the right rehabilitation methods, because rehabilitation is not one thing. Rehabilitation is multiple tools, multiple approaches, and that's how you need to see it when you think about shared decision making and rehabilitation. In shared decision making, you're going to hear a lot about patient decision aid. So this is a patient decision aid. This is one of the first patient decision aid that was designed in the province of Quebec. So it's a tool, it's an evidence-based tool, and it's used to show the patient the evidence about the impact of antibiotics when you have upper way infection. So we know that we're taking too much antibiotics right now. And the patient decision aid showed that, well, if you take antibiotics, you're perhaps going to improve your symptoms from a few hours to maximum a day. But you can also have adverse event with antibiotics. So the risk may not be sufficient to reach the benefits. And this is what a patient decision aid does. And what they found in this first study is when you expose the patient to the evidence and you let them express their value and preferences, they show actually a 25% reduction in the overuse of antibiotics. And from a health system perspective, 25% reduction in overuse of any diagnostic or treatment, it's a massive achievement. So we knew that shared decision making can have very important impact about the choice of different options. But remind yourself that shared decision making, it's a communication strategy to share evidence. It's not a technique to influence a patient choices. So that's very important to remind. is it relevant in our field? So most of us work in chronic pain. Is it relevant? So we've started this work in 2019, and in 2019 there was a overview of clinical practice guideline that was published in the British Journal of Sports Medicine, one of our biggest and strongest journal of, across the world. And what they found is that across different types of MSK condition, patient-centered care was proposed in almost all clinical practice guidelines. And so you've seen before that patient-centered care is the overall approach. So this means that we should use shared decision-making tool that was proposed by a clinical practice guideline. When you look at the Canadian Pain Task Force that was published, so this is basically our national plan to deal with chronic pain, it's explicitly said that we need to use shared decision making between people living with pain and healthcare professional, and most likely in complex situations such as opioid prescribing. And choosing wisely, a movement in Canada that is designed to reduce overuse of inappropriate care, also propose using shared decision making as an approach to navigate complex decisions. So it's very relevant to our field. But do we do it as a rehabilitation professional? Well, the answer is no. So this study is from 2018. They look at consultation from rehabilitation professional, and they found that approximately 2/3 of participants still use rather paternalistic approach in routine care. So this means that in rehabilitation, we're still really much into prescribing protocols and standardized approach without the input of patient. This is what the evidence shows us. And they conducted further surveys in Australia. And what they found 2 years ago was that this phenomenon of paternalistic approach is actually present in almost any condition that requires rehabilitation and in which, as rehabilitation professional, we're highly involved. So this is relevant, and this is why in Australia they are pushing for more training about shared decision making in undergraduate school. So very relevant to look into this in more detail. So now you need to understand how we actually measure shared decision making in clinical practice. I'm going to show you two tools. So the first one is the option scale. So this is what we call a third observer approach. So the tool is basically to assess a clinical consultation. So you can use that if you are a clinical professor and you're evaluating student in your practice. And so it's really about, does the observer observe the technique and the behavior of the clinician, like drawing attention to alternate treatment option. If the clinician support the patient to become informed, if the clinician give information or check understanding about the option, if the clinician elicit patient preference, and if there is an effort to integrate the patient elicited preference. So this is one of the tools that mainly use in research effort. So you'll understand that it may be difficult to assess this in a rehabilitation consultation, more so in the evaluation phase, because you have this decision about the protocol at this time, but not in any consultation. But there is another tool that's very beneficial for us, and it's called the decisional conflict scale. So it's a tool, it's a complex tool for research, so 16 questions with a 5-point Likert scale that assess the state of uncertainty about the course of action to take. And so, as I said previously, uncertainty is really a core concept of shared decision making. So you can assess uncertainty. And so this is a strong tool, and it was used and validated for over 20 years in research. And this is the center of our Canadian survey. So as Karine said, in 2021, we launched the Decide Pain study, which is a decisional need assessment for patient-centered care, pain care in Canada. So I'm not going to go into the methodological details of the survey because, well, time is ticking, but just some key methodological elements that we did. So this is a pan-Canadian survey from Well, it was launched in 2022 from 10 provinces. So we work with leisure marketing, and we were not able to reach territories, but we were able to have a representation of all 10 provinces. And so we recruited 1,649 adults living with chronic non-cancer pain. And what's interesting about our survey is that we use stratified proportional random sampling based on the population and chronic pain prevalence in each provinces. And this is for two things. First, to achieve representativeness, and two, to reduce selection bias that we often see. So selection bias in survey is that you're more gonna have responded to your survey. Like if you survey people over social media, you have a higher chance of having people who have a specific point of view about your topic. So this is a selection bias. And so here we did it at random across the province to reduce this bias and have a more appropriate response to our survey. And so it was a lengthy survey, approximately 60 questions that cover a lot of domains around shared decision making. But the most important is that we assess the decisional conflict scale, so the sense of uncertainty. And why it's important is because with this scale, if you score over 35 or over 37.5, it indicates the presence of what we call clinically significant decisional conflict. And this is linked to poor outcome and decisional regret. And we also assess decisional regret. So decisional regret is, I went to a clinician, we discussed option, I chose an option, and after I made the decision, I regret my decision. And this is very bad, because people who regret certain decisions have a reduced adherence, and adherence is very key to improve our clinical practice in rehabilitation. And we also assess the control preference scale, which is the degree to which the patient want to be involved in the decision. And so we're not going to go more into details. If the protocol is free to look over the internet, so you can have a more detailed reading and thinking about this. So the result. So there is a lot of result to discuss, but I'm going to focus today on 3 different results: the role in the decision-making process, decisional conflict, and difficult decision. So the first thing we were looking into is the role that the patient actually took in the clinical consultation is the same as the role that they desired. And there are 3 different types of role. So passive role is a role in which a clinician do all the decision. An active role in which the clinician don't do anything, only the patient decide. And the collaborative role is when they share decision. And interestingly, what we found is that approximately 25% desire either a passive role or a full active role, and 76% actually desire a collaborative role. But more importantly, we found that approximately 50% of all people did not match between the role that they wanted and the role that they actually took during a clinical consultation. So we really, when you start a clinical consultation, discuss upfront with the patient the role that they want in making the decision. Then we go into the core, the decisional conflict. So let me remind the full definition. So it's a state of uncertainty about the course of action to take. This state is likely when making choices involving risk or uncertainty of outcome, high stakes in terms of potential gain and losses, the need to make value trade-off in selecting a course of action, and anticipated regret over the positive aspect of rejected option. So complex definition. When you hear this definition, you're supposed to think about, well, there is going to be decisional conflict when there is hard decision, like surgical decision, where there is risk. And this is what we thought. We thought, well, decisional conflict may not be that high because of that. Well, we were wrong. What we found is that a third of all responders, so it's over 1,000 patients from all over Canada, a third of them score for clinically significant decisional conflict. And if you reduce the definition a little bit, 70% experience decisional conflict. So these are people who consulted the healthcare system, and after their consultation, they are more uncertain about the best course of action to take for their care. A third. So this is very important, very significant. And so where does this come from? And so we asked them about, well, what were the difficult decisions? And what we found is that 97% of the sample actually experienced a difficult decision across their care pathway. And we asked them any types of difficult decision, and we were able to find more than 30. So navigating options for pain care is very complex because patients reported over 30 different difficult decisions. And so time is going fast, and I still have something to talk about, but just to tell you that difficult decisions are about anywhere in the care process. So choosing when to consult a medical practitioner, the diagnostic approach to use, the treatment, and even daily life generates difficult decisions for certain people. I let you the slide here that goes into more detail for the difficult decision. And you can look at them when you have more time, but this is very interesting, and the result will be published and accessible open access very soon. So overall, almost all respondents face at least one difficult decision across their care pathway. A third experience high level of clinically significant decisional conflict. So people have unmet needs and desire to be involved in the decision about their care. So what does it say? Well, it justifies the development of shared decision-making intervention to address difficult decisions and reduce decisional conflict. So I'm just going to take a few minutes about possible solution, because sadly today my aim was to increase awareness about shared decision-making and decisional conflict at the national level, but I do not have the solution for you right now. But a possible solution that you can integrate now is to screen for uncertainty in your clinical practice. And there is a tool for that, which is the SURE test. So it's designed from the decisional conflict scale, only 4 questions. Do you feel sure about the best choice for you? Do you know the benefit and risk of each option? Are you clear about which benefit and risk matter most to you? And do you have enough support and advice to make a choice? If the person answers yes to all these questions, it is very unlikely, based on the evidence, that they're going to have decisional conflict. But if they answer no to at least one, it means that you have more work to do to resolve these decisional conflict. So this is solution number 1. You can screen for uncertainty. Solution number 2 is to use a new kind of tool, which is called a patient decision aid. So it's a tool to improve the communication of the evidence from the professional and the communication of value and preferences from the patient. It's different than a patient education tool. So I've shown you here, these are 2 patient education formats. So you see a lot of evidence in there. This is super interesting. It was developed for patient, but it does not elicit patient value. So this is not a patient decision aid. This is the archetype of a patient decision aid. We're not going to go into details, but what you see is there are different steps, and you need to pre-identify the option and the evidence so that it makes sense when you're talking with the patient about that. Is it useful to go into this field? The answer is yes. So this is a Cochrane review that was updated just 2 weeks ago about the evidence concerning patient decision aid. And now we are at a total of 200 different studies involving over 100,000 patients on patient decision aid for 71 different decisions. And what they show, you use this type of tool, there is high certainty evidence that you're going to be able to improve participant knowledge and decrease decisional conflict. And unfortunately, this review found that there is very few work done in pain care. So we have a high level of decisional conflict and not enough tools to support clinicians in doing that. And one of the reasons why it's difficult to develop tools in that field. And I just took a photo from the American College of Rheumatology guideline for osteoarthritis. And like what you see here is that there are over 40 options, pharmacological and rehabilitation, to choose from when you have one simple or 3 simple musculoskeletal condition like osteoarthritis. So it is very complex for the clinician to navigate all this evidence. And so that's why most likely we're getting into protocol types of proposal for a patient. But I think we need to take a step back and just look at all the possibilities and find a way to better engage patient in choosing their own program from all these possible options. And some tools are coming. So this was published 2 years ago only by the College of Family Physicians. And so you see the same usual format. And so this is free. You can access it with this reference. This is free. And this is done, this is designed to be used in primary care practice, and you see the evidence concerning different types of options like exercise, non-steroidal pharmacological option, or spinal manipulation, and it helps the patient make their choice. And here with that tool, they also categorize that options for which benefits likely exceeds harm, and option for which harm likely exceed the benefits. So this is the kind of tool that is coming for your clinical practice very soon that will help you navigate and implement shared decision making. And there is an inventory. It's not perfect, it's not complete, but it's free, and you can see many types of decision aid here. So my time is up. Just to conclude that shared decision making, for me, it's an additional value for rehabilitation professional to support primary care team by educating patient to treatment option based on best evidence. It helps us achieve the full potential of a rehabilitation professional role in medicine. It acknowledges the rehabilitation professional expertise and optimize the value of the consultation. And there is this expectation from both general practitioner and patient to use shared decision making in interprofessional collaboration. And I just end by saying, no pressure. It's a strategy to improve quality of care. It's not an obligation, and it's not a substitution of your clinical judgment. Voila, thank you very much.
Thank you very, very much. And I love your passion that comes through when you speak about shared decision making. That's really nice to see. I had a question with respect to shared decision making, understanding that it's so important in healthcare. An important piece that sometimes is overlooked is really the adjudication or the case management on some of these files. And I was curious if there is any literature evidence to also support a shared decision making model with the adjudicators or claim managers that are working with some of these individuals, and or whether that also extends to the rehab team as well.
Well, yeah, thank you for this. So my view on that is that shared decision making is the ideal place to implement it is with the case manager, because that's the first point of contact. That's where the integration of care is done. So that's where all the options are exposed. This is where the first discussion are exposed. This is where the patient come back to if there is a chosen option that was not appropriate. So integrating it in at the case management interface is very, very important, and it's going to help us do a better linkage with the rehabilitation team. However, this is an underused approach because this is about not just one patient decision aid, but implementing it in a care model, because case management is not
I think you're frozen for a moment. Let's give a minute to see if it comes back. There you are. Oh, but now I can't hear you. There we go. I can hear you now. Sorry about that.
I said I'm being kicked out by my own computer. That's a new one.
Okay, I'm gonna have one follow-up question and then we'll move on. But my other follow-up question with respect to that is, if we wanted to, knowing how important it could be to implement a shared decision-making model, what steps would you suggest if someone has never done this, especially on a case management side, how they would go about that, and if there's a specific one of the decision aids that you showed that might be the most appropriate to start with?
Personally, the first step I would choose is to use the tools I've proposed to assess the uncertainty. Perhaps even like if it's at case management level, when you have more time, go with the full 16 question and look at the answer. Or there are other tools that if you click the links in the presentation, people can see other tools like the SDMQ9 question. That's the first thing. Just take the time to take a few minutes to assess the current state in every patient, because the answer to the question is going to tell you like what exactly how to describe your population. And from there, you can choose if you need an intervention or tools. But really, the first step is to understand what's driving decisional conflict. And you can implement shared decision making just by talking with the patient without a tool. Once you understand, like, okay, uncertainty. So the way I'm presenting the information right now, in many patients, it generates uncertainty. How can I change my verbatims when I talk about that? So really, the simplest and most valid way to do that right now is to use the evaluation tool, I think.
Perfect. Thank you so much. That was excellent.
Thank you, Dr. Ducret. As JC said, I love your passion when you talk about this and the excitement that it brings in terms of different ways we can look at this model and how we can use this information with our clients. Because oftentimes we wonder, like, why is it this way or why is it that way? And how can we better understand and facilitate moving things along? So I really appreciate that. So thank you for sharing that. We're just going to take about a 3-minute break right now so that you can stretch your legs, take a bio break, grab a coffee, and we'll just come back at 1:19, 1:20, just so that, and then we'll reconvene and we'll start with our next speaker. Hi, everyone. Welcome back. Just like to introduce Monique Miller, our Director of Business Development for Atlantic Canada, and she'll be introducing our next speaker for today.
Thanks so much, Julia, and welcome everyone. It's my pleasure to introduce our final speaker for today. Dr. Sylvie Bourgeois is a clinical psychologist and the National Director of Mental Health Strategy and Innovation for Lifemark. Dr. Bourgeois has 20 years of experience as respected and award-winning executive leader in interdisciplinary mental health program development, implementation, and evaluation in both public and private sector organizations. Her area of focus has been primarily in the space of mental health risk mitigation, from prevention to clinical intervention, for high-risk occupations in safety and security organizations, along with psychological safety promotion in the workplace. She enjoys educating leaders on strategic approaches to sustaining healthy workplaces and supporting the mental health of various workforces. Dr. Bourgeois' topic today is resilient employees and psychological healthy workplace. Are these organizational buzzwords or achievable goals? Welcome, Dr. Bourgeois.
Hello, everyone. Bonjour. I will share my screen. Is it visible?
We can see it.
We can see it. Okay, thank you. Thank you, Monique. I'm honored to be speaking to you today about this important topic, one that balances the narrative of mental illness, disability, to also include trajectories of mental fitness and resilience. Today, I'll be coming to you based on my understanding of the psychological literature on this topic, and as one that has worked not in an academic setting, but in large organizations where occupational health, the health and well-being of high-risk employees was the focus, and where I sit now in serving third-party funders and insurers whose clients fall in the mental health continuum of needs. So I recognize that today we have employers, we have supervisors who have staff and colleagues within organizations. We also have disability case managers and adjusters who have clients who have been ill, injured, and are on their rehab journey. So I'll try to focus on themes that cross-cut your various roles, and hopefully you'll be able to take away some things that apply to you in your own roles, in your own workplaces as well. So the goals of today is for me to try to increase your understanding of resilience based on the psych literature, to demonstrate how organizational psychological safety factors actually support directly the mental health and resilience of individuals. And finally, to provide you with some tools to foster resilience in your staff, in your clients, recognizing the impact of healthy workplaces on individual mental health. So, mental health problems. Is this a weakness of our time? Are younger generations just less stress tolerant and less resilient? Is rising mental health disability claims just a new normal? And is it now the responsibility of employers and workplaces? Well, the answer is it depends, and context really matters. Why are these themes so prevalent in our awareness, in our media today? Basically, our fast-paced culture results in people seemingly working longer and harder, meeting tight and competing deadlines, context of job insecurity, managers managing more complex work relationships and dynamics in the virtual context and in person, while we're all staying constantly connected through mobile devices, and where the social and geopolitical context of today seems to be right in our backyard in a repeated fashion. And then we have our family lives that are just increasingly busy, filled with diverse activities, And then our social networks are a bit more scattered. The social fibers of yesterday is slightly different. People are suffering with from a bit more isolation. So all this to say that today's context creates increasing demands that can outstrip our own resources of even very healthy, resilient, and can lead to chronic stress, burnout, performance issues in the workplace, and even real mental health and physical health conditions. So just so I can better understand who you are today, and for us to get a sense of who we are as a community, I'll have Craig do a survey, and we'll see where we land on 3 questions based on a Likert scale answer. So if you can just, I believe, click on what you see on your screen on whether you agree, somewhat agree, or disagree with each of these 3 statements, we'll be able to then see the distribution. So, Craig, can I assume that what we see here with the first question, okay, it seems like it's a split. So we have an audience that seems to be equipped, which is great, because then we can engage in a discussion at the back end. So half of you believe that you'll have a pretty good handle on how to be resilient and be good at stress, while half of you somewhat agree, and a small portion believe they disagree with that. Thank you. Next one. So my workplace invests in prevention by providing mental fitness training and resources to employees and supervisors. So the key point here is your own workplace and the word prevention. Okay, here we have, looks like almost a third, which is not surprising. Most workplaces tend to have health benefits, supplemental health benefits for employees, but proactively engaging in prevention initiatives to support mental fitness training and resilience is something that is just starting to be noticed as an added value. So good for you for those that agree in that you're in those types of organizations. Okay, and lastly, Craig, the third one. So my or your client, if you're in disability management's employer, has taken tangible actions to address psychological safety factors in the workplace. So the concept here is the organizations and psychological safety factors. So again, distributed. I'm liking the fact that it's slanted on the positive, where it sounds like you're working or are aware of your clients' environments that are starting to notice the importance of the environment, the organization's factors in helping to promote mental health and resilience in individuals. Okay, thank you for that. Okay, so I will continue. So just so we all are on the same page, what is resilience? Basically, it's the concept of the ability to bend and not break under extreme stress. It's the ability to adapt well in the face of adversity, threats, significant stress over time. And resilience is not mental health, it's part of mental health. The concept of mental fitness is more the process, the practice. Just like physical fitness, it's practicing psychological skills that underpin resilience. So it's more of that lifestyle. So what are the factors in the literature that are individual based that promote resilience? So I'll level set and run through 10 factors that we consider psychological factors that underpin resilience. Because if we don't understand what it is, it's hard to know how to enhance it, promote it, both in the individual and also at an organizational level. So the first one is based on literature, research with people who've bounced back from adversity. We can safely say that people who are resilient have realistic optimism. So what does this mean? It means that they pay close attention to negative information that's relevant to the problems they face. However, unlike pessimistic individuals, they don't remain focused on the negative. They tend to disengage rapidly from problems that appear to be unsolvable. So in other words, they know how to cut their losses and turn their attention to solvable problems. So related to this is acceptance, accepting the reality of our situation, assess what we can and cannot change, and redirect efforts toward that which we can change. Another one is cognitive flexibility. People who are resilient tend to be flexible in the way they think about challenges and flexible in the way they react to problems, either emotionally or physically or behaviorally. They tend to reframe things as challenges and really sort of adopt, what can I learn from this? Where's the opportunity to learn in the face of adversity? Other examples of cognitive flexibility is finding humor in stressful situations, especially from the first responder literature. We know that first responders that use Black humor is actually quite adaptive and protective in the face of potential critical incidences or traumatic stress. So finding humor in the right context with the right people can help and help people bounce back and be resilient. Another one is gratitude, and there's lots out there that support the use of having gratitude moments every day in spite of being faced with chronic stress, and looking at things that you have gratitude and are grateful for is something that people who are resilient tend to do. What else? Adaptive coping. Resilient people shift from one coping strategy to another depending on the circumstances. Sometimes they'll use emotion-focused coping, which is really more about looking internally and regulating their own physiological arousal, their own emotions. And sometimes they'll be more proactively problem-solving, looking at external environment and modifying those. So again, this concept of flexibility, not using the same tool in one's toolbox for everything, is what characterizes resilient people. Similarly, emotional regulation. Resilient people are not afraid of emotions. They know that it's there as a sign. They name the emotion, not in a good or bad way. They just name it to tame it, which means they identify it, they see it as a signal that something needs their attention, and then they regulate it. They adjust the emotion to the just right intensity so that they can think about, respond effectively to the dilemma or the situation at hand. How do we regulate emotions? Usually it's through physiological downregulation or the lever of our thoughts and looking at what we say to ourselves about a situation. So resilient people, whether they've been taught this through therapy or they just do it naturally, know how to emotionally regulate. Related to this is resilient people know about brain-body connections. They know that the importance of physical fitness. For better mental health, research has shown that physical training and mastering physical challenges can actually lead to improved mood, cognition, and emotional resilience. So physical fitness, and probably to this audience, you're well attuned, actually increases resilience in the face of traumatic stress and adversity. And the importance of recovery. By having chronic cumulative stress, one cannot continue to sustain. In order to bounce back, we need to have time to recover through proper sleep and also proper nutrition and nutrients. And finally, a last group is resilient individuals have good social support and social connectivity. Why? We know that people that are well connected through social fibers, this actually helps to decrease physiological responses to stress. It helps to appraise stress as less threatening because there's a sense of being in it with others. There's a sense of cooperation, and that activates reward centers in our brains and then helps to bolster our ability to cope and bounce back. Resilient individuals know their values and try to meaningfully engage in activities, their priorities, their pie of where they focus their time and how they focus it is aligned for the most part with their values. And that helps to give them meaning and purpose. So being aware of your moral compass, being aware of your own values and making intentional choices actually is something that characterizes resilient individuals. And finally, we also know from literature that religion and spirituality are highly correlated with resilience, the ability to bounce back from adversity. Why? One element that we know, especially for religion, is that there's attendance to religious services, connecting with a community of like-minded individuals with similar values actually connects with that sense of social support, that sense of optimism, that sense of altruism. And so religion and spirituality, which is connected to your moral compass, practicing meditation, are all aspects that characterize and support resilience. So now that we know what resilience is truly, are people that are resilient, are they born like it? Are they just lucky that they can ebb and flow in the face of stress in life and be able to be flexible, or can this be trained? More and more, we're recognizing that, yes, resilience, i.e., learning psychological skills and practicing those, what we call mental fitness skills, that process can actually increase individuals' ability to cope and bounce back from cumulative stress and adversity, which is what we call resilient outcome. So just to illustrate resilience training, psychological skills training, if we position it in the mental health continuum, would fall in the green and the yellow. So the best time to benefit from resilience training is when one's healthy, when one's battery are pretty charged. So people like yourselves that consider being relatively good at stress can always benefit from training. Or the red is really the reactive, the clinical intervention. And if we load up at the front end or upstream, what we have is when people who are resilient or are skilled at being resilient, if they inadvertently fall ill or injured, they are already better equipped to bounce back and move to the yellow or the green, which is what we want, which is what is resilience. So the programs or the training products that are out there to help in this area of mental fitness and resilience, skill building, if they're evidence-based, should be based on individuals' supply resources, taking into account their own external pressures, their own values, and their own personal and work context first, and then applying some of the psychological skill elements that I've just described. So these programs would look at helping an individual learn to cognitively reappraise better. It would look at training physiological downregulation of the stress response. It can teach skills on emotional regulation. It can help individuals learn what their values are and help them align and make more meaningful, intentional choices in their lives. It can also look at where they're at with social connections, look at the gaps if they're low, and help them create ways to increase those, both in their personal lives and their work lives. And ultimately, it can also help with behavioral skills like problem solving into action when you're faced with interpersonal conflict or when there's a person-job misalignment. And ultimately, it can also teach individuals environmental changes, how to modify your environment in order to be more resilient. So I'll just tell you what, like, because this is a newer area of research and service, the ones that I know of that provide and reinforce in this space come in the form of self-guided virtual programs in mental fitness skill building. One is one that we have at Lifemark that is internet-based cognitive behavioral skills training that can be self-directed or supported by a coach. Another is by an organization that we're learning to know more, and it's the Atlantic Institute for Resilience that have developed an evidence-based self-guided psychological skills training platform with a coach as well. Others could be just through professional assistance and doing this work on a one-to-one or through group psychoeducation. And other formats actually come from reputable organizations like the Mental Health Commission of Canada, or even institutes that offer evidence-based worksite group training programs that purport to reinforce mental fitness and psychological skills. So now that we've focused on the individual, does the story stop there? Or is there another 50% of the story when we think about resilience and helping individuals be more resilient? Well, employees interact with their environment, and we also know that workplace factors either support or negatively impact mental health and resilience. And so there's data that's starting to come out that organizations who invest in mentally healthy workplaces, the physical environment, the workplace environment, is actually good for staff and good for business. Return on investment data is starting to come out. So what do I mean when I say mentally healthy workplaces? Basically, it's the elements, the factors that come from the standards, the national standards for psychological health and safety in the workplace that you can find on the Mental Health Commission of Canada's website. They're on the slide there. I won't go through them, but these are evidence-based factors that we know that if an organization addresses intentionally it does actually make for a great workplace, but it also impacts the individual workers' overall mental health, engagement, and morale in the workplace. So how do these relate to burnout? A word on burnout. Often when we hear burnout and we say our employees are burnout, we kind of jump to the conclusion that it is like an individual responsibility. It's an individual's vulnerability. And so we need to like refer them to EAP or refer them to resources so that they can kind of fix themselves. But you've probably heard that we need to be shifting the concept and our understanding of burnout from an employee, an individual responsibility, to a collective we responsibility. Why? Because the dimensions of burnout, someone feeling overwhelmingly exhausted, usually is due to unmanageable demands and inadequate recovery. Think of the psych factors that I just showed you. There's feeling of cynicism and detachment from the job. Doesn't occur out of the blue. It's often resulting over time from value conflict and feeling emotionally distant from the job, with supervisors and peers not necessarily responding to that and seeing why that is happening. And ultimately, the third dimension is that a person's sense of ineffectiveness and lack of accomplishment is prevalent. But often, again, it doesn't occur in a vacuum, usually related to a lack of recognition, unrealistic standards, lack of control. So what can organizations do in this space? Well, it really speaks to the psychological psych safety factors that we saw. But here it applies directly to minimizing burnout. And if we minimize burnout, indirectly, we're creating conditions for people to be mentally healthy and be resilient. So needing to look at sustainable workloads, more in the control of the employer than the employee to a certain extent. Looking at job control and choice. Research has identified a clear link between a lack of control and high levels of stress and burnout. So when employees have some degree of control in their micro schedule throughout the day, that goes a long way. Recognition and reward, clearly related to minimizing burnout if done well. Supportive community at work. Again, I cannot overemphasize the importance of social connections, social support in the workplace. And even more so, how are we looking at that when there's hybrid work or even full-time virtual work, exposing challenges that are new for supervisors and employers to consider. And then lastly, fairness, respect, concepts of social justice, and having matched values. So having clear organizational values that employees know and can make their own evaluation of how well that is matched with their own values. And if these are done well, we have these outcomes that support resilience. So my final section of the presentation is really, so what can you do? What are some of the tools that you can do as a supervisor, as a leader in organizations? What are the things that we have under our control? Levers such as developing systematic approaches to address psychological health factors in the workplace. This will not occur by itself. We need to plan, we need to identify priorities, implement and evaluate our actions, and then adjust them. We need to actively seek input from our employees on work-related stressors and their impact to be able to proactively make changes. We also need senior leadership buy-in on these initiatives. If there's no modeling and no buy-in from the top down, many of these fail to be sustained in the longer term. Finally, we need to be monitoring the impact of virtual and in-person work on both the individual, team engagement, wellness, and morale. The concept of prevention, not just having a whack of resources for clinical intervention, but also what are we doing from a prevention perspective where resilience is. And really, finally, looking at where your supervisors are with the knowledge and skills to be able to intervene early and being able to look for changes in mood, behavior, and performance, and support the employee in connecting with resources. Ultimately, it's about communicating often because mental health and resilience is really everyone's responsibility. So I will stop there and know with the slide that can be shared with you, I've also attached some valuable resources that provide practical tools on the concept of resilience and workplace mental health. Thank you.
Thank you, Sylvie. That was great. I have a couple questions myself and a couple that have come through the chat here. Acknowledging, of course, that we were in quite a time of change during the COVID-19 pandemic, and most things moved to online unless you're an essential worker. I was curious if that impact and that shift specifically to virtual and working on computers every day, if there was any impact on resilience from that respect as well, or if it was the same regarding virtual work versus in person. I'm just curious about that.
Yeah. The jury's still out. The organizational psychologists out there are actually actively studying what the concept of hybrid or virtual or telework has on employee mental health and resilience. But what we do know is that really it depends on the person, on the nature of their work, and really their supervisor's ability to still lead and engage in order to provide results. Because we know that there are some benefits of remote work. People will say it gives me some flexibility, there's reduced commute time, I'm able to fit in, personalized workspace, I have a bit more autonomy. But we also know the downside is that people can feel more socially isolated. The virtual becomes a bit more transactional, which if not acted by supervisors, can lead to employees feeling less connected, less aligned with the mission and vision of the organization, and can slowly start to get into it's me, myself, and I. And at some point, if it's not meeting my needs, well, off I go to somewhere else. So it's really this delicate balance of recognizing the pros, but also appreciating some of the risks to having people work virtually and finding ways to make it not just transactional and productive, but also engaged and integrative as well.
That makes sense. I guess we'll see when the research comes out. I'm sure people are studying that for sure. With respect to resiliency and some of those principles that you had mentioned throughout, is there a way that case managers or adjudicators can start to further that conversation with some of their claimants, or is there a way that they can broach kind of that resiliency conversation with their claimants?
And I think basically the importance of resilience at the individual level and the organizational factors that we know promote resilience are also very important predictors of return to work. And so what I'd encourage is for adjusters and case managers to see their individual not from a disability, but what are the capacities? What have we done to bolster their resilience? Because if we've only treated the depression or treated the anxiety and we've not really looked at, are they further skilled to continue to face the stressors as they return to work? We might only have done half the job. So to have this discussion with their clients about where they're at in their ability to be good at stress and how confident they are to be able to be skilled as they're returning to work. And on the flip side, talking to the supervisors that are going to be reintegrating, like, are they aware that the workplace factors are also very important for the client? And are there some that are in this red flag or yellow flag that we knew before the client went off work that we might need to be looking at to attenuate, so that the workplace factors and the psychological skills of the individual are a bit more aligned in order to promote a better return to work experience?
Thank you so much, Sylvie, for your talk today. You're also a very passionate speaker, and I know you really really love this area in terms of talking about how we can build resiliency in organizations and put in place services and resources to help individuals with coping strategies to handle the increase that we're seeing in terms of mental health issues that are out there in the workplace, given increasing workloads, demands, personally as well, and really appreciate all of us, including our clients, are experiencing some of these in different degrees at different points in time in our work journey and our personal lives. So thank you for sharing this information with us today.
Thank you for having me.
I'd also just like to thank all the participants for attending today and for your questions that you put in the Q&A. We really can't thank you enough for your partnership in working with us here at Lifemark. We do hope you've enjoyed today's conference and found some tools, some techniques, information that you can use in your day-to-day work. We will be sending out, as I mentioned, a copy of a link to the recording of the conference, so you can share this with your colleagues or rewatch a speaker, etc. With that, there will be a short survey, and we would love to get your thoughts and ideas for our fall conference on different topics you'd like to hear or speakers. We really want to make these the time that we spend together valuable in the sense of giving you some of those things that can help you with your job in terms of handling cases, etc. So we really look forward to getting your feedback, and we look forward to seeing you in the fall. And we'll be sending out information closer to the end of summer, early fall about our next conference. So have a wonderful day, and thanks for joining us today.